Hello, Clinic Review family. I'm glad to see you again. This is Dr. Sharon with Clinic Reviews. And today we're going to be talking about signs and symptoms of complications of diseases and what to do about it. So this falls under physiologic adaptation. This is not there that you do not have to know how to read the question and interpret it correctly, which is why I think this is very valuable to you. We are going to cover a number of things like shock, diabetic ketoacidosis. There'll be some things like that here. I think some ABG abnormalities in these questions, but it's not just about using common sense and clinical reasoning. With these questions, you have to know content and you have to know how to think through the question correctly. So that's what we're going to be focusing on today. I think it'll be very helpful to you. So let's go ahead and get started. Hello, Clinic Review family. You know, this is Dr. Sharon with Clinic Reviews, the home of the very best NCLEX review in the entire universe. In my opinion, Mark Klimek is the GOAT of NCLEX prep. And if you go to clinicreviews.com, you can find the products that we sell. And that includes a 21 plus hour online on demand NCLEX prep. It's very good. It doesn't cover the same things that we cover in this channel. This channel is really for those of you who maybe don't have the money to pay for the Clinic Review. That's one of the reasons we do this. Not everyone can afford to pay for the services we offer, and we do want to offer you some help. It's also so that you can have trust in us, so that you know that we're real people, that we're teaching quality content, and we're a small company. There's only a few of us that work at Clinic Reviews, and we don't advertise. So we want you to get to know us a little bit so that you feel like the product that we offer is quality. So if you want to get to know us a little bit, you can sign up at Clinic Reviews for our small group tutoring. It's online, it's Zoom. You can meet me over Zoom live if you want to. With our small group tutoring, you can sign up for our streaming service where you can find all the videos that I have taken off the YouTube channel, plus all the videos that we have there now. And you can sign up for the online on-demand NCLEX prep. So let's go ahead and get started. These are not necessarily just common sense and clinical reasoning. You have to have a certain amount of knowledge of content in order to answer these questions. A client with diabetic ketoacidosis is receiving an insulin drip. The nurse notes potassium of 5.8. The priority intervention is 2. Continue current infusion and recheck potassium in 2 hours. Hold the insulin infusion and notify the provider. Prepare to administer sodium bicarbonate. Administer a dose of potassium lowering resin. Okay, so we've got DKA. And with DKA, you know that the person comes in with high blood glucose, a low pH, because that's the acidosis, and a high potassium. The potassium ends up being high because the acidosis causes potassium to leave the cell. So acidosis, they have a high acid base, and the body tries to compensate for that by moving hydrogen into the cell. Okay, so that's a compensation, but in order to move hydrogen into the cell, the potassium has to exit. So the key thing in treating hyperkalemia with DKA is shifting the potassium back into the cell. So how can you shift potassium back into the cell? You shift it back into the cell by giving insulin. Continue the current infusion and recheck in 2 hours seems like a reasonable thing to do. Hold the insulin? No, we're not going to do that because it's treating the hyperkalemia as well as the hyperglycemia. To prepare to administer sodium bicarbonate, well, they're acidotic, but by giving the insulin, we're going to actually treat the acidosis as well, so we don't have to do C. Administer a dose of potassium lowering resin. That would be okay if we weren't already treating them with insulin. So the insulin is, in fact, the treatment for this. Okay, so hyperkalemia is a complication of DKA, but we treat it by giving insulin, and they're already getting that. So that's what we're going to continue to do. A postoperative client suddenly becomes hypotensive, tachycardic, and diaphoretic. The nurse's first action is to elevate the head of the bed, check the surgical dressing for bleeding, administer a bolus of IV fluids, obtain a stat hemoglobin level. All right, hypotensive, tachycardic, and diaphoretic. So they're post-op. So when I see hypotensive and tachycardic, I say they're probably losing fluid somewhere or losing blood somewhere. That is a good clinical judgment to make, and diaphoretic. So all those things go together and say, I bet they're bleeding out somewhere. Okay. So when someone's bleeding out, do we elevate the head of the bed? No. Do we check the surgical dressing for bleeding? Yes. Do we administer a bolus of IV fluids? Yes. Do we obtain a stat hemoglobin level? No, that's not what we do first, right? That's not our first thing. We already know they're probably bleeding out. We are going to get a stat hemoglobin level, I'm sure, at some point, but we've got to stop the bleeding first. Because if you don't stop the bleeding, then you're not going to be able to correct the underlying problem. So we could give IV bolus fluids, but if we're not applying pressure, if they're bleeding, then that's not really going to help anything. So our first action is we have to check and see where the bleeding is and get that stopped if it's in fact coming from the surgical incision. A client with diabetic ketoacidosis has an ABG of pH 7.28, PaCO2 32, and bicarb 15. Which intervention has the highest priority? Now, they've already told us that they're in diabetic ketoacidosis. Diabetic ketoacidosis is a metabolic acidosis, so you really don't have to look at the ABGs. The ABGs are just consistent with a metabolic acidosis. So if you don't know how to do ABGs, you can type in Climic Rome or Climic ABGs into YouTube, and it'll come up respiratory opposite, metabolic equal. Metabolic equal means the pH is down and the bicarb is down. So we have a low pH and a low bicarb. That's metabolic acidosis, metabolic equal, which is a diabetic ketoacidosis. Administer IV regular insulin infusion. Begin slow IV infusion of sodium bicarbonate. Encourage oral fluids to correct dehydration or monitor blood glucose every hour. Now, this is a highest priority question. It's a best question. Remember, when you get a question like this, there's going to be more than one right answer, and you have to make a clinical judgment on what your highest priority is. So you have to say, which one thing do I have to do? Now, remember, insulin in a DKA patient is a type 1 diabetic. They're not making any insulin. So you have to treat them with insulin. So that the insulin corrects the hyperglycemia, the insulin corrects the acidosis, and the insulin corrects the hyperkalemia. It does all three of those things, because if you can start to allow the glucose to be metabolized, because it's not being metabolized, if you can start to get glucose metabolizing, you're going to slow the release of ketones. The acidosis is going to go away. You're going to start to shift hydrogen back out and potassium back into the cell, and it corrects all three of those things. So which intervention is the highest priority? Well, A is giving insulin IV. You have to do that. Begin sodium bicarb. If you're only going to do sodium bicarb, that's not going to correct the pH because you're still making a ton of ketones. Encourage oral fluids to correct dehydration. They're probably dehydrated, but that's not going to correct the underlying problem with it, which is ketosis and acidosis. Monitor blood glucose every hour. You certainly want to do that, but you have to give insulin, y'all. You have to. It's the highest priority. You're not going to be able to get them out of this acidosis unless you do that. A client on continuous hemodialysis reports muscle cramps, hypotension, and nausea during treatment. Which is the most appropriate intervention? Most appropriate is the equivalent of best or highest priority. Increase dialysis solution sodium concentration, slow the rate of ultrafiltration, administer IV mannitol, give an oral carbohydrate snack. So when you get a question like this, remember you're looking at the signs and symptoms of complications and treatments. So you're saying you have to make a clinical judgment on what's going on here. So when you see hypotension, you should be thinking, what can cause hypotension? You say, well, bleeding can cause hypotension, low volume can cause hypotension, septic shock can cause hypotension, cardiogenic shock can cause hypotension, neurogenic shock can cause hypotension. Shock, essentially, right? Shock, it leads to hypotension causes shock. So the question is, based on what you know, which type of shock would it be? Well, it's not cardiogenic. They don't have any heart problems that they've told us about, and don't assume they do. It's not neurogenic. They don't have a spinal cord injury. It's not septic. They don't have an infection. There's no signs and symptoms of infection. So it has to be a volume problem, either bleeding or low volume. And they told us that hemodialysis, if you don't know this, it removes fluid, y'all. It removes electrolytes, it removes fluid, it removes waste. It does all those things. So this question is saying, do you know what hemodialysis does? Can you recognize the complication of hemodialysis, which is hypotension, and do you know what to do about it? So you say, well, it's got to be a volume problem. This has got to be leading to hypovolemic shock. So increase dialysis solution sodium concentration. Well, if I increase the dialysis sodium concentration, I'm going to pull more fluid out. I don't want to do that. Slow the rate of ultra-infiltration. Well, if I slow the rate of ultra-infiltration, I decrease the amount of fluid that's being pulled out, and it's certainly, I'm doing it more slowly. So sometimes it's not that they've pulled out too much fluid, it's that they pull it out too fast. So if I slow it, I can slow down the amount of fluid, the rate at which we're moving fluid. Administer IV mannitol. Well, mannitol is a diuretic, but it's used primarily for increased intracranial pressure. Nevertheless, I don't want to give a diuretic when they're hypotensive. Give an oral carbohydrate snack. That would be for hypoglycemia. And these are not the symptoms of hypoglycemia. Muscle cramps typically are associated, well, they are associated with electrolyte imbalance, which is consistent with removing too many electrolytes with the dialysis. Nausea is a vague symptom that's usually associated with kind of anyone not feeling well. So these are classic symptoms of the hypovolemia and electrolyte imbalances associated with dialysis. So out of all, remember, the right answer is the right answer because of the other answers. So the only one that makes any sense here is B. A client with acute pancreatitis has a serum calcium of 6.8. Which clinical finding is most important to report? Positive Trousseau sign, hyperactive bowel sounds, paresthesias around the lips, or confusion. So we always report unexpected findings. Now, on the new NCLEX, they would have told you what the normal range for calcium is there. So this is hypocalcemia. So it's low potassium, okay? So they're hypocalcemic. The pancreatitis is interesting, but it's really a hypocalcemia. So the question is which of these symptoms are consistent with hypocalcemia? Now, we teach about hyper and hypocalcemia in the big 21-hour plus hour clinic review. So I'm just going to give you a little hint here. The calcemias are associated with neuromuscular problems. So like tremors, paresthesia, muscle weakness. These are all things that are associated with they're associated with calcium imbalance, and the most common is hypocalcemia. So hypocalcemia causes neuromuscular irritability. Okay, so it's positive Trousseau sign, neuromuscular irritability. Well, Trousseau sign is a contraction of the carpals or a spasm of the carpals, a carpal spasm. Remember, carpals drive the car. Tarsals walk on tar, carpals drive the car. So what happens is you're going around doing blood pressures. You pump up the blood pressure cuff, and they're sitting there, and then all of a sudden they go, like the claw. Okay, that's a positive Trousseau sign. That's neuromuscular irritability. That's what that is. Hyperactive bowel sounds. Could that be neuromuscular irritability? Well, you have muscles in the colon that result in peristalsis. So if you have irritability of those muscles, you're going to have increased peristalsis, which is hyperactive bowel sounds. And then paresthesias is your classic neuromuscular symptoms associated with really any electrolyte imbalance. Now, confusion, you might go, well, that's brain. Okay, that's not really what we're talking about here. When we're talking about neuromuscular irritability, we're talking about more peripheral signs of neuromuscular irritability. Okay, so confusion. Now, if I were purely guessing, I would have guessed confusion just because I never like confusion. So confusion is something I almost always report, but I'm just explaining to you how you can make a clinical judgment in this case if you understand the pathophysiology. A client with cirrhosis, which is liver, develops asterixis and confusion. The nurse recognizes these as signs of hepatic encephalopathy and should do what? Restrict protein intake, administer lactulose per order, elevate the head of the bed to 90 degrees, place the client in Trendelenburg position. So here, you don't even have to identify what the problem is. The problem is hepatic encephalopathy. So they have cirrhosis, which is liver. Hepatic encephalopathy is liver. So what causes hepatic encephalopathy? It's actually an increased ammonia level. And asterixis, which is hand flapping, and confusion are associated with hepatic encephalopathy. So the symptoms are consistent with the complication identified. You should know what asterixis and confusion are associated with hepatic encephalopathy. You should know that. So the question is, how do you treat it? Well, it's an increased ammonia level, which you should know. E. coli are the number one producer of ammonia in the body. So what happens is the E. coli are producing ammonia, and normally that ammonia is taken back to the liver where it's metabolized and excreted. But in this case, the liver's not doing its job, so we're not getting rid of our ammonia. So which of these things gets rid of pneumonia? And the answer to that is lactulose, gets rid of ammonia. So they drink it. It binds with the ammonia in the gut, because remember, E. coli produces ammonia, it binds with the E. coli in the gut, and it excretes it, and they're going to be a pooping machine after they take lactulose. A client with pancreatitis suddenly develops guarding and rebound tenderness. The nurse's priority action, which means the best thing to do, priority. You can only do one thing. Which one thing do you have to do? Just like I said, you have to give insulin with DKA. What do you have to do now? The nurse's priority action is prepare for abdominal CT scan, palpate the abdomen gently, administer morphine as ordered, monitor serum amylase and lipase. So if you have enough information that you can take action, then you should take action. If you don't have enough information to take action, then you should do more assessment. So the question is, do we have enough information here to take action? Well, I know they have pancreatitis, but now they have guarding and rebound tenderness, which is more associated with peritonitis. Okay, pancreatitis and peritonitis are not the same things. So now I have signs and symptoms of peritonitis. That's guarding, rebound, tenderness. So I say, do I know why they have peritonitis? No, I don't. I have no idea why they have peritonitis. So we need to figure that out, right? So preparing for an abdominal CT scan. Now on the NCLEX, listen, on the NCLEX, when it says prepare for, like prepare to intubate, prepare to give this, prepare to for a CT scan, when it says prepare for, that does not mean you're going and pulling the ET tube out to intubate them, or it doesn't mean you're calling down to CT scan and saying, I'm bringing them down right now. That's not what prepare for means on the NCLEX. On the NCLEX, prepare for means in your head, you know you're probably going to have to do a CT scan. That's what prepare for means. So the question is, do you think you're going to have to do a CT scan? And I say, well, it's a good way to figure out why they might have a peritonitis. That seems like a really good way to do that. So that seems like a good answer. Palpate the abdomen gently. Well, that's assessment, but the question is it further assessment? Is it going to, if I palpate the abdomen gently, is that going to tell me anything I don't already know? Well, it'll tell me if they have guarding and rebound tenderness, but I already know they have guarding and rebound tenderness. So palpating the abdomen is not going to give me any additional information. It's assessment, but it's not assessment that's going to help me. Administer morphine. Well, now we're going to treat the pain. They have rebound tenderness and guarding, but I don't know why they're having pain. So do I want to mask the pain? I mean, what if I give them morphine and the pain goes away and then I go, oh, good, took care of the problem and we don't do anything else? Like, that's not good. Monitor serum amylase and lipase. That's for the pancreatitis. That's not for the sudden change. It suddenly develops, right? So the only one here that is appropriate is to prepare for abdominal CT scan. A client post-carotid endarterectomy exhibits unilateral facial droop and slurred speech 4 hours after surgery. Your immediate action is to, immediate means first. You have to do this right now. Elevate the head of the bed to 45 degrees, administer ordered aspirin, perform a cranial nerve assessment, check blood pressure, and notify the surgeon. So this is the kind of situation where you say, do I have enough information to identify the complication? So they've just had a carotid endarterectomy. Endarterectomy is when they go in and they clean out the carotid artery because it's occluded. Like, it's probably not 100% occluded, but it's probably like 98, 99% occluded. And they're going to clean it out because the risk is they're going to have a stroke. If they don't clean it out, they're going to have a stroke. Now, what's the risk associated with a carotid endarterectomy? The risk associated with a carotid endarterectomy is a stroke. So why would I do something that could cause a stroke when they're at risk for stroke? The risk for stroke without the carotid endarterectomy has to be higher than the risk for stroke with carotid endarterectomy. But you still know there's a risk for stroke. So I know that carotid endarterectomy is a risk for stroke, and now they're having signs and symptoms of stroke. So do I have enough assessment to say they're probably having a stroke? Yes, I do, because they've just had something done that's a high risk factor for stroke, and they're having clear, classic signs and symptoms of stroke. So do I have enough information to do something? I think I do. Elevate the head of the bed. Is that what I do for stroke? No. Administer ordered aspirin. Maybe. Perform a cranial nerve assessment. That's further assessment. So I'm ready to do something. I'm not sure that I need to do a cranial nerve assessment, check blood pressure, and notify the surgeon. There it is. See, I think they're having a stroke, and I'm going to do a stroke alert. Okay. And what I don't want you to go say is, well, I'd have to do the NIH stroke scale. Well, you would. Yes, you would. But you've got to call a stroke alert first. And in this case, the reason we're not calling a stroke alert is because they didn't just come into the ED from home, or they're not sitting on a general med surg unit with, pneumonia, and then all of a sudden they have signs and symptoms of stroke. You call a stroke alert when it's an unexpected. They suddenly have this stroke symptoms. You're like, whoa, call a stroke alert. Let's do an NIH stroke scale. Here we have a known risk factor for stroke, clear signs and symptoms of stroke. I'm calling the surgeon because the surgeon's going to have to take him back to surgery and figure out what happened, because something just happened. A client with nasogastric suctioning for bowel obstruction begins to complain of dizziness and shows a blood pressure drop from 130/80 to 90/60. What complication do you suspect? Metabolic alkalosis, electrolyte imbalance, hypovolemia, or sepsis. So now you have to tell them what you think the problem is. Instead of saying, what am I going to do about it? I have to tell them what I think the problem is. So you have to look at the circumstances. The circumstances, all we know is they have nasogastric suctioning for a bowel obstruction. They haven't told us anything else. So you can't assume anything else. You can't assume they're diabetic. You can't assume they have an infection. You can't assume they have a heart problem. You can't assume any of that. So suddenly their pressure drops. So I say to myself, shock. I mean, that's what I'm thinking, right? Maybe shock. Well, what types of shock are there? Septic shock, cardiogenic shock, neurogenic shock, hypovolemic shock. So septic shock, is there any sign or symptoms of infection? No. Cardiogenic shock, do they have any problems with heart disease? No. Neurogenic shock, have they had a spinal cord injury? No. Hypovolemic shock, is there any evidence they're losing volume? Yes, they've got nasogastric suctioning. They could be losing volume. So I say to myself, this must be a volume problem. Is there any answer that's consistent with saying this is a volume problem? And I say, yes, C is consistent with a volume problem. So I'm going to pick C. Now, just so that you know, metabolic alkalosis is a risk factor associated with nasogastric suction. They can lead to metabolic alkalosis, but metabolic alkalosis doesn't result in a drop in blood pressure. So the symptoms are not consistent with metabolic alkalosis. An electrolyte imbalance is a risk with nasogastric suctioning. But the electrolyte imbalance isn't consistent with a drop in blood pressure. That's not what you see with an electrolyte imbalance. And D can't be right because there's no symptoms of infection. So that can't be the right answer. So you do have to use clinical reasoning, but you also have to know how to read the question correctly. Okay, if you notice there were a bunch of weird editing in this, it's because there was just a lot of issues with recording this video. So I kept losing my connection, and then it wasn't hooked up to my microphone. Like, you don't know how many times I had to record this video. So the editing is probably weird. So I apologize for that. I hope you find it helpful to you. This idea of signs and symptoms of the complications and what to do about those complications is a higher level question, right? It recalls multiple steps. You have to have a certain amount of knowledge. You have to have a certain amount of testing competency, and you have to have a certain amount of confidence. So it requires all those things. If you got 50% of these right, you're probably okay. If you're like, oh man, I missed them all, then okay, you need to practice this. If you could only study one thing, I would say you have to study your fundamentals. This is a really good video because you will get questions like this, but it's not going to be the majority of your test. You will have to know your fundamentals. You're going to get lots of fundamentals questions, okay? So that's my recommendation to you. I'm actually going to do another video covering the same content using SATA questions because I do think it's important to know how to answer these questions. So thank you for being a part of the Clinic Review family, and I will see you later.